Hello. So today let's learn about hydatid disease. Okay. So we'll cover the Sabiston, Bailey, Schwartz, shackelford, Harrison, and blumgart. The best is given in blumgart. Okay. So we'll start from the ba- our basic book Sabiston. Okay. So hydatid cyst is also known as echinosis. So it's a zoonosis, and the definitive host is a dog. D for dog. Just remember definitive host dog. Okay, and humans are intermediate host and accidental intermediate host. So humans are accidental intermediate host, and no human to human transmission is seen. Okay, so there are many types of echinosis, but the echinosis subspecies, but echinosis granulosus is most common type. This can be as echinosis granulosus is most common type. Okay, so other ones are echinosis multilocularis and echinosis ligatus. Okay. Okay. So in dogs, the adult tapeworm attached to the ileum of the definitive host. Okay. Okay, and sips are also intermediate host. So it is most commonly seen in sips rearing area. Okay. Okay. Humans are accidental intermediate host. Already told you, and the this is the end stage of parasite. If parasite infect the humans, the cycle ends in human only. Okay, in human they generally present in duodenum. Okay, so in dog it is ileum, in human it is duodenum, and the stage of larva is oncosphere. Okay, oncosphere. Okay, and that penetrates the mucosa. Okay, so oncosphere reach the liver most commonly via hematogenous route. Okay, so via hematogenous route it is reached to the liver. Okay, 3 weeks after infection a visible hydatid cyst develop. Not that important. Okay, so that cyst is composed of 3 layers. The first one is pericyst. It is derived from the host tissue. Okay, many times the pericyst is derived from the host. Okay, and the cyst wall itself has a 2 layer. The outer is ectocyst and inner is endocyst. Okay. Okay, and the inner one is also known as germinal membrane. Okay, endocyst is germinal membrane. Okay. Okay. So in definitive host, scoliosis develop into adult tapeworm, but in intermediate host they differentiate into new hydatid cyst. So in humans and sheep they develop only cyst, but in definitive host like in dog they can develop in adult tapeworm. Important difference. Okay. So freed brood capsule and scoliosis form the hydatid sand. So scoliosis, as far as scoliosis form the sand along with brood capsule. Okay. Okay. Daughter cysts are also true replicates of the mother cyst. Okay. Okay. Calcification of hydatid cyst, however, does not always imply the cyst is dead. This is can be one liner. Okay, so calcification does not imply the cyst is always dead. Always. Okay, so hydatid cysts are diagnosed in equally in man and woman. Okay, though no sex predilection. Okay, and mostly in the right side of the liver, and generally are solitary, single. Okay, and clinically they when the patient present to you it is generally large and asymptomatic. Okay, large and asymptomatic. Most common presenting symptom are abdominal pain along with dyspepsia and vomiting, and most common sign is hepatomegaly along with jaundice and fever. So symptoms are abdominal pain, dyspepsia and vomiting, and signs are hepatomegaly, jaundice and fever. Rupture of the cyst can occur into peritoneal, pleural and pericardial cavity. Okay, but the most commonly in biliary tree. Okay, so most common rupture in biliary tree. Okay, okay. And if it is rupture in peritoneal cavity and all, it can cause fatal anaphylactic reaction. Okay, so ultrasound is most commonly used worldwide for diagnosis. Okay, so in simple hydatid cyst, budding sign is present. So it contains free floating hyperechogenic hydatid sand. Okay, and rosette appearance is seen when daughter cysts are present. So rosette appearance means daughter cysts are present, and calcification of the wall of the cyst highly suggestive of hydatid disease. Okay, okay, okay. Treatment of hepatic hydatid disease is primarily surgical. Okay. So older patient with a small asymptomatic densely calcified cyst, conservative management can be considered. So old patient, small asymptomatic densely calcified, you can go for conservative management. Okay. So pre-operative steroid was recommended but not universally used, and when its patient is intra-op, anesthetists are advised to keep ready epinephrine and steroid available. Okay, when you open the abdomen, you should pack the abdomen so that you can avoid the spillage. Okay, okay. Cyst is usually aspirated through the closed suction and flushed with scoliocidal agents such as hypertonic saline, and then cyst is unroofed. If you do excision, it is also known as pericystectomy, or you can also do marsupialization, leaving the cyst open, drainage of the cyst, and omentoplasty and partial hepatectomy. Okay. Okay. So both radical resection or conservative, that is drainage and evacuation surgical approach, appear to be equally effective. So radical means resection, you have to do resection, and conservative means drainage and evacuation. When bile duct communication is diagnosed, it is surgery should be done meticulously, and simple suture repair can be done. Okay, and pre-op ERCP may be necessary. Okay, okay. So they ask generally in PG or FMG, generally ask what is the full form of pair. So it's a puncture, aspiration, injection, and re-aspiration. Okay, P for puncture. Okay. Many books write percutaneous also, but if you have to choose one, go for puncture. Surgery remains the treatment of choice, already told. So treatment of echinosis is with albendazole or mebendazole. Okay. So shrinking cyst in many patients with echinococcus granulosis infection. Okay. So pre-operative treatment may decrease the risk of spillage. Okay. Okay. Medical therapy without definitive resection or drainage should be considered only for widely disseminated disease or poor surgical candidate. Okay. Okay. So this much was from Sabiston. Let's see what Bailey given. So we will not repeat the same points. Okay. So this is also known as dog tapeworm. Okay. So intermediate host are humans, sheep, and cattle also. Okay. So here cyst given nicely. So cysts are consist of three layers: outer pericyst derived from host organ. Intermediate is hyaline ectocyst. Okay, it is non-infective, and the innermost is endocyst, which is germinal membrane, and this contain viable parasite. Okay, and this form the daughter cyst. Okay, so echinococcus multilocalized, in which the cyst is spread from the outside by actual invasion rather than expansion. So cyst is spread outset by actual invasion. So invasion is present in multilocularis. Okay, okay. So WHO has given ultrasound based classification. Okay, on based on the status of activity of the cyst. Okay, sorry. So this is outdated, still given in New Delhi. Okay, so the based on activity of cyst, there are three groups. Group 1 is active group, cyst larger than 2 centimeter and fertile. Group 2 is transition. 2 is transition. 1 is active. A is active. 1 is active. 2 is transition and 3 is inactive. Okay, degenerated. Unlikely to. So 3 is calcified. 3 is calcified. C. Okay, unlikely to contain viable proctoscoliosis. Okay, so it can colonize every organ in the body. Okay, the patient in question may it give you it. The patient is sheep farmer. Okay, that's why I have highlighted this. Okay, liver is most common organ affected, and next one is lungs. Okay, so a patient is having pain, dull pain because of stretching of liver capsule, and if the patient is have dyspnea, it may be because of pulmonary lesion. Okay, and cyst may communicate with biliary tree. In that case, patient will present as obstructive jaundice. Okay, and unexplained headache may give rise suspicion of cerebral hydatid cyst. Okay, okay. So this is CT scan of hydatid cyst of pancreas. Okay, not liver, pancreas. So let's see classification of hepatic hydatid cyst. Previously it was given as a Garby classification, but now it has been changed. We will see Garby classification also later. So CL means cystic lesion, unilocular anechoic cystic lesion, cystic echinosis 1. Okay, so it contains the fine internal echo that represent proctoscoliosis, that is called hydatid sand. So you have to remember, one is hydatid sand. Okay, okay. Then 2 contains the honeycomb, 2 names, honeycomb, cartwheel and rosette formation. So this is 2. Okay, that is cyst with internal septation representing the wall of daughter cyst. Okay, multivesicular. Okay, now 3 is also divided into 3A and 3B. 3 is transitional stage. Okay, so 3A is daughter cyst with detached laminated membrane, and 3B is daughter cyst inside the solid matrix. So inside the solid matrix is 3B, and 3A is also known as water lily sign. We will see in other books. Okay, and then 4 and 5 are inactive or degenerated cyst. Okay, so daughter cyst can no longer be seen in 4. So bag of wool is wool is 4 letters, so 4, and 5 is calcification. Okay, okay. Now come to diagnosis. So in diagnosis you may get rage eosinophil count, ELISA test or electrophoresis. So ultrasound and CT scan are investigation of choice as per Bailey. So treatment should be done in tertiary unit, and the pair full form already explained, or antihelminthic drug like you can use albendazole or praziquantel also. Okay. So in summary form they have written CT scan is best imaging technique. So if you have to choose one, you go for CT scan. So these are the picture based question you may get. Hydatid cyst of abdomen disseminated, and this is MRI. Okay, okay, and this is double edged wall. So hydatid cyst that separated after travel injury. Okay, so this question has been asked. Okay, so now comes what are the scolocidal agent. So hypertonic saline 15 to 20%, the 20% is specific, ethanol 95%, and providine iodine they have given Okay, 5% providine iodine. Okay, but as the blumgart say, you should never use providine iodine. Okay. Active cyst should be first treated with full course of albendazole. Okay. In laparoscopic management, you should do laparoscopic marsupialization of the cyst, that is called deroofing, and removal of the cyst, the most common procedure. Okay. And if the cyst is small and superficial, a cystopericystectomy should be performed. Okay. A few points regarding pulmonary hydatid disease. The lung, as already said, lung is second most common affected. Okay, mostly the right lung, since liver is in right side and lower lobe. Okay. In chest radiograph, you may get meniscus or crescent sign. It is a sign of impending rupture. When cyst rupture, then water lily sign on CT scan. So in X-ray, you will see the meniscus and crescent sign. Okay, so cyst has not yet rupture, impending rupture. And in cyst, if cyst rupture, water lily, so it's rupture, that's why it's floating. So water lily sign on CT scan. Okay. Okay. So mainstay of treatment of pulmonary hydatid disease is surgery. So in both liver and lungs, the mainstay treatment is surgery. Okay. So medical treatment is less successful, and surgery, if surgery is not possible because of poor general condition of the patient, diffuse disease affected both lungs, and recurrent or ruptured cyst. So in case of ruptured cyst, also you should go for medical management. Okay, because of anaphylaxis and all. Okay. So, and what are the surgical option? Cystotomy, capnotase, pericystectomy, segmentectomy, and pneumonectomy. Okay. 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 These are the picture of meniscal sign, water lily sign on CT scan. Okay. Water lily sign also showed on X-ray, but it is mainly seen on CT. Okay. Okay. Any important point from Schwartz? Okay. Cyst can also present in lungs, spleen, brain, and bone. Okay. Already told, hydatid cyst is most common in ship raising area. Medical treatment with albendazole relies on drug diffusion through cyst membrane. So albendazole diffuse through the cyst membrane. Echinococcus multilocularis, also known as alveolar echinosis. Okay. Let's see what is given in shackelford. So they are generally solitary cyst, and cyst expansion is slow. Symptoms are unusual until cyst size reach 10 centimeter in size. Most common presentation like non-specific, that is malaise, weight loss, chronic wasting. Okay. Other symptom like obstructive jaundice, anaphylaxis, already told. Okay. A diagnosis of echinococcal infection is confirmed based on serological demonstration of antibody response. Okay. So false positive reaction seen in infected with other helminthic organ. Okay. Ultrasound is first line diagnostic test for patient with echinococcal disease. Hydatid cyst is distinguished from simple cyst by the presence of daughter cyst. Important line. Okay. If you want to see the cyst biliary fistula, you should order MRI with MRCP. Okay. So goal of hydatid surgery should be inactive infection with cyst content. Okay. Prevent spillage of cyst content, evacuate all viable elements, and manage the residual cavity. Okay. Okay. The surgery begins by isolating the area immediately adjacent to cyst with disinfected soak pad to reduce risk of contamination. Already told is colloidal agent. Citramide is new one, not told previously. 5% citramide is also colloidal agent. Okay. Okay. Even in post-op, you should give albendazole or mebendazole. Okay. So the benefit of giving albendazole are reduce the risk of intraperitoneal recurrence. Residual cavity may be left open to the peritoneum. Okay. So leaving pericyst intact. In that case, albendazole should be given. Omental flap may be also used to fill the cyst cavity. Okay. Percutaneous, you do pair, already told. It should be done under CT or USG guided. Okay. Okay. So before doing pair, you should you should rule out cyst biliary communication. Okay, by doing cholangiography. Okay, that is MRCP. Okay. Okay. Let's see what blumgart given. Blumgart is given very nice. Okay, so we'll take bit time. Okay, so HYDATID is also called cystic echinosis. Okay. Okay. And polycystic echinosis caused by echinosis vogeli and oligarthus. Okay. Apart from affecting liver and lungs, it is also affect spleen, kidney, heart, and bone and central nervous system. Okay. Surgery is only definitive treatment. Okay. For large, active, symptomatic, and complicated hydatid cyst, percutaneous technique should be done in uncomplicated cyst or high risk of medical status performance. Medical therapy should be used in inoperable cases, disseminated disease, or complementary with surgery or percutaneous treatment to prevent post-op recurrence. Okay. So genotype 1 is most common, widely distributed. Genotype 1. So this echinosis granulosus has hexacanth embryo. So humans are aberrant intermediate host. Cysts grow 1 to 5 centimeter per year. Okay. The pericyst is also known as adventitial layer. Okay. The ectocyst is middle acellular layer resembling egg white. Okay. The endocyst or germinal epithelium, the innermost layer, the only living component is endocyst. Okay. That is responsible for formation of other layer as well as hydatid fluid and brood capsule. Okay. So hydatid fluid contains electrolytes and protein, and the fluid is antigenic. Okay. Vesicle rupture within the cyst. Within the cyst, the proctoscoliosis pass into the fluid and form the hydatid sand. Already told. Daughter cyst is similar to mother cyst. The only difference is absence of adventitial layer. So daughter cyst does not create any inflammation to the host, so there is no adventitial layer. Okay. So this is the picture of pericyst, ectocyst, endocyst. Okay. The annual history, natural history of hydatid is first place of cystic growth, and second is aging and progressive evaluation. Erosion of the cyst most commonly in bile duct. Okay. Then pleural space, then peritoneal cavity. So most commonly in bile duct. Okay. Compressive effect can lead to obstructive jaundice. So cystobiliary communication is most common complication. I already told. So minor communication less than 5 ml lead to cystic fluid drainage. Major rupture when lead to passage of cyst contents. So classical triad of biliary rupture in cystic hydatid disease is biliary colic, jaundice and urticaria. Classical triad is biliary colic, jaundice and urticaria. Okay. Minor leaks will cause flushing and urticaria. Major rupture can cause fatal anaphylactic reaction. Okay. Size of the cyst is important predictor of cystobiliary communication, and the cutoff is generally taken as generally 10 centimeter. Okay. Leukocytosis, eosinophilia, hyperbilirubinemia, and elevated ALP and GGT is also associated with high risk of cysto that you may seen these findings. Okay, may lead to the cystobiliary communication. Okay, then the peritoneal rupture is third most common complication. Okay, after intrabiliary rupture and allergic reaction. Okay, so when the young age, when because of the trauma in young age, cyst diameter more than 10 centimeter and superficial cyst are risk factor for peritoneal rupture. When there is term called secondary echinosis, when daughter cyst from rupture hydatid cyst into peritoneal cavity lead to multiple cysts, in that case known as secondary echinosis. In intrathoracic rupture known as hydatid pneumonia, so there is a bilobronchial fistula, so you will see biloptosis, a pathognomic sign. Biloptosis seen in when hydatid pneumonia, the bilobronchial fistula. Okay. So spontaneous cyst cutaneous fistula seen in elderly. Okay. The most severe complication is cystovenous communication. Most of the patient usually asymptomatic. So if the patient is having calcified or dead cyst, they are also seronegative. Okay. So already told that WHO USG classification. So that was I was telling. So it is replaced the previous classification that was based on the it is replaced the previous classification. Okay, that active, transition and inactive. So now WHO has given the new classification: possible case, probable case and confirmed case. Okay. So in possible case, clinical, epidemiological history, imaging finding and serological positive for echinococcus. Okay. In probable case, the serology positive. Okay, for 2 tests. Okay, serology positive for 2 tests. Okay. Okay. And in confirmed case, along with these two, you will see the demonstration of proctoscoliosis and change in ultrasound appearance. Okay, so probable case serology positive, probable case 2 test positive for cystic echinococcus. Okay, so there is 2B, so 2 test, 1B only one, confirmed case. Okay, so most common symptom is right upper quadrant or epigastric pain, and most common finding is hepatomegaly. Okay, rarely abnormal in patient with uncomplicated hydatid cyst. So serum alkaline phosphatase raised, If it is rupture in biliary tree, you will see transient elevation of cholestatic enzyme and hyperamylasemia and eosinophilia. Okay. So IgG elevation, mainly IgG1 and IgG4. Plain radiograph of abdomen and chest should be taken. To you will see the thin calcification delineated a cyst or elevated hemidiaphragm. Okay, in chest X-ray. In USG is a screening method of choice, and more characteristic sign with cyst within cyst, also known as cartwheel or honeycomb cyst. Okay, so this table is very important. So this compare GERB and WHO classification. So this is based on active, transitional and inactive. So GERB 1 is CE1, so snowflake appearance. Okay, free floating proctoscoliosis. Okay, so GERB 3 is WHO cystic echinococcus 2. Okay, so you will see 2 in 2 you will see cartwheel, rosette like or honeycomb. All are two words. Wheel like, rosette like, honeycomb like. Okay, so both WHO 1 and 2 are active. Okay, so in GERB 2 and WHO 3A both are same. So this is in this is transitional phase, and you will see water lily sign. Okay, and in 3 GERB 3 and WHO 3B daughter cyst in solid matrix, and 4 already told wool of ball. Okay, 4 5 are inactive. Okay, so WHO is this is screening method of choice. So it help in the treatment planning and follow up. So contrast enhanced USG help to distinguish hydatid from neoplasm. Okay, and it will also help to guide percutaneous treatment. CT is best for detect number, size and location of the cyst. Regarding MRI is superior to CT in demonstrating internal composition of the cyst wall, biliary involvement and neural involvement. So MRI is best diagnostic method to demonstrate floating membrane, and there is one sign called snake sign. ERCP can be diagnostic and therapeutic also. ERCP has high sensitivity in diagnosing intrabiliary rupture, but MRI should be preferred for diagnosis. So let's come to the treatment. Surgery remains gold standard, already discussed many times. Okay. Most common approach for treating hepatic hydatid disease is surgery. So this principle already we discussed. Now surgery is mainly for complicated cyst, large CE2 and CE3B cyst, multiple daughter cyst and superficial cyst. Superficial, just remember. And contraindication for surgery as diffuse hepatic cyst, dead cyst, inactive cyst, that is C4 and C5, very small cyst, and not suitable for surgery due to general condition. Okay. And then surgical approach, mainly there are two types: conservative surgery when pericyst is not resected but the germinal and ectocyst are resected, and radical surgery when pericyst is included in resection. Okay. Okay. So radical surgery is also known as pericystectomy, cystopericystectomy, capsulectomy, radical cystectomy and subadventitial cystectomy. This radical surgery is also divided into closed and open technique. Close technique when you do not violate the cyst wall, and if there is a partial or total cyst excision after opening and sterilizing the cyst, known as open technique. Okay, so this should if the peripherally located small cyst, you should do closed total pericystectomy. Okay, if the cyst is located big centrally located cyst, then you have to do open subtotal pericystectomy. Central and big, open. Periphery and small, close. Then sculocidal substance. So here it is mentioned, formalin and betadine should never be used under any circumstances. Okay. Toxicity to bile duct mucosa explain why communication between the cystic echinococcus. Uh, so bile duct must be carefully checked before the use of any proctosclerocidal agent. So simply it is saying you should before applying any sclerocidal agent, you should look for communication. Okay. So WHO said 20% hypertonic saline is preferred proctosclerocidal agent. So 20% hypertonic saline. Okay, when you are performing surgery, and if you are doing percutaneous procedure, so 20% hypertonic saline or 95% of alcohol. You can use both. So ideal case for laparoscopic cystectomy is uncomplicated and cyst located within anterior segment, and preferably in liver periphery away from major vessel or duct. And the surgical complication include fistula, intra-abdominal abscess, wound infection and hemorrhage. And predictor for morbidity include age, previous surgery, cyst size more than 10 centimeter, multiple cyst, centrohepatic cyst and cystobiliary communication. And then follow up. So abdominal ultrasound first month after discharge, then after every month during first 4 years and annually thereafter. Okay, if there is any suspicion, you should do abdominal CT. So if there is rupture in biliary tract, so if it is diagnosed preoperatively, you should go for ERCP. Okay, to manage obstructive jaundice and cholangitis. Okay, if there is intraoperative diagnosis, you can go simple suture, but there are complications associated with suturing. Okay, if the fistula is less than 5 centimeter, treated by suturing. Okay, so main disadvantage of this is prolonged biliary leakage and subphrenic abscess formation. So rupture into peritoneum, it is a life-threatening complication. In that case, peritoneal cavity should be washed with sclerocidal solution or anti-helminthic treatment started as soon as possible. Regarding percutaneous treatment, already everything explained. Blumgart also said 30% hypertonic saline, but according to WHO, you should mark 20%. And the wait time is 10 to 15% after injection. Okay. The aim of pair technique is destroy the germinal layer. This can be asked. What is the aim of pair technique? Okay. Other pair technique are also given, like catheterization technique known as pads and percutaneous evacuation of cyst content known as PEVAC. Okay. So based on WHO ultrasound grading, there is a treatment given in CE1 and CE3A treated by pair. Okay. So pair technique used for cyst is smaller than 5 to 6 centimeter in diameter. So in CE2 or CE3B, okay, Modified catheterization technique along with surgery. So 2 and 3B, catheterization technique with surgery. Okay. Regarding medical management. Okay. So it how medical management help. So it reduce cysts, decrease infectivity and avoid relapse. So it is useful in disseminated or inoperable hydatid disease. So albendazole, mebendazole already told. So dose are regarding albendazole, dose is 10 to 15 mg per kg body weight per day, and it is given along with fatty meal to increase bioavailability. So current recommendation for medical treatment alone when the in CE1 and CE3 less than 5 centimeter size, and praziquintal also given, and efficacy in combination with albendazole, the efficacy increase when it is combined with praziquintal. Okay. So ideal agent for prophylaxis in preoperative and post-operative setting to prevent implantation proctoscoliosis is combination therapy. Okay. So combined treatment increase the level of albendazole sulfoxide in serum and cystic fluid. Okay. So anti-infective treatment alone is reserved for small, medium size isolated cyst or multiple inoperable cyst in the liver or multiple organ. So albendazole treatment also used with pair and with surgery. So albendazole should be started 1 week before to 2 to 3 months after interventional procedure. Okay, side effect of albendazole are abdominal pain, nausea, vomiting, pruritus, dizziness, alopecia, rash, headache. But the leukopenia, eosinophilia, icterus and mild elevation in transaminase also seen. So all patients should be monitoring by leukocyte count and liver function test. Okay. Contraindication for chemotherapy is pregnancy. Okay. Chronic hepatic disease and bone marrow suppression. So pregnancy is important one. You should not use chemotherapy. So wait and watch approach should be done in degenerating CE4 and CE5 type of cyst. Okay. Even in small CE cyst. Okay, small. Okay. 4, 5 and small CE1. And follow up should be at least 5 years. Every 6 monthly for first 2 years. It is going to be different. So as albendazole is hepatotoxic and leukopenia are the most severe adverse effect, so albendazole sulfoxide measurement are extremely useful to assess patient observation and adjust drug doses. Albendazole sulfoxide. Bit about Echinococcus multilocularis, that is also known as alveolar echinococcus. It is seen in fox. It is infiltrative neoplastic growth with potential metastasis, mainly to the lungs, spleen, bone and brain. In USG, you will see cystic-like structure. FDG PET is used for detection of metabolic activity in alveolar echinococcus. Okay? And radical resection is the only curative procedure. Okay. So done. Last one is just 1 to 2 minutes. The Harrison. What is latest Harrison says? Okay. So pair is contraindicated in superficially located cyst and cyst communicating with the biliary tree. Okay. And the medical therapy with albendazole alone for 12 weeks to 6 months result in cure in 30% or improvement in 50%. So medical therapy should be given from 3 months to 6 months. 3 months to 6 months. Okay. And surgical resection remains the treatment of choice for Echinococcus multilocularis. Okay. Okay. In that case, albendazole should be given the lifelong indefinite period. Okay. If the complete resection is not possible. Okay, then there is nothing new, so we'll stop here. Thank you.